Thank you very much, Professor Sunetra. It looks like we might have more panelists than we have an audience, but that's okay. If we can also ask people to come towards the front as much as possible, so that we can be closer together. And then as we've indicated, we'll be very, very strict with time. That means that when we say it's out, it's out. So please, apologies in advance. This is not out of being rude, it's because we just want to make sure everyone has a chance to speak, and we don't want the last panelists to be rushed. And we want to have time as well for the audience to ask questions. So we will start without further ado with our first presenter, Mariya Saeed. Mariya Saeed is a member of the Society for Health Education, so that's the IPPF member association in the Maldives. And she served as vice chairperson from November 2023 to September 2024. Mariya has over 32 years of experience as a medical laboratory technologist, and she formerly led the Thalassemia and Diagnostic Laboratory Services. So welcome, Mariya. She will be talking to us about addressing reproductive health challenges posed by thalassemia in the Maldives, and she will specifically focus on examples from She Maldives program.
Thank you very much for the introduction. Assalamu alaikum and a very good afternoon to all of you. Well, my topic is addressing reproductive health challenges imposed by thalassemia in the Maldives. Insights from She's outreach program. And the presentation is co-authored by Dr. Naila Ibrahim Didi, also known as Dr. Naila Firdaus. And she is the co-founder of Society for Health Education, and she is the first gynecologist of the country as well. And she has contributed in the field of reproductive health in a very for a very long time. The objectives of my presentation is to evaluate the impact of She's outreach program on addressing reproductive health challenges associated with thalassemia in the Maldives. Thalassemia is one of the huge public health concerns of the Maldives, and I think the beta thalassemia carrier percentage is the highest is in the Maldives from globally. So from this, we have done assessing the prevalence of beta globin variants, identifying high-risk islands, evaluating the effectiveness and outcome of genetic counseling in facilitating reproductive decision-making. The methodology was secondary data from She Thalassemia Prevention Initiatives. One of the focus areas of She Maldives is thalassemia. It is a very high public health concern in the Maldives, and she has a thalassemia screening lab which also can do genetic analysis. And we have had a national thalassemia prevention program since 1996, and we have the data we have used for this has been more than 100,000 people were tested. So it is 1/3 of the population. So from the screening and the DNA studies and genetic mapping, what I mean by genetic mapping is we have different variations of thalassemia carriers in different islands. We have noticed that there are pockets of different variants, which is very prevalent in some areas of the country. The results of the study showed that high prevalence of beta thalassemia globin variants and prevalence of anemia in the carrier population of thalassemia and the hemoglobin variants. So the result is 1 in every 5 person is a carrier for beta thalassemia. So we have included people from above 12 years of age in this screening program. That is because we have a legal age for marriage is 18. So before the marriage, it is very important to know if you are a thalassemia carrier. That is why we have selected the age group starting from 12 years. So 1 in every 30 marriages are between two carriers, and 1 in 120 live births is a thalassemia major. This is, of course, when we did not have any genetic counseling and premarital counseling for this issue. So we have found that 18.2% of the population carries a variant of a hemoglobinopathy. And specifically, if you look at only beta thalassemia, 16.3% of the population carries the gene. And beta thalassemia is a recessive gene inheritance disorder. So, from the results, we have understood the critical need for preconception genetic counseling, because the variants that we find in our population has risks of uh, carrying a child who can be transfusion dependent for the whole life. So pre-genetic counseling is very much, we have to design it for the pockets of population where each type of variants are prevalent. And premarital thalassemia screening mandatory was, we have made it mandatory before registration of marriages. Because of the outcome of She Thalassemia Screening Program, we were able to advocate for premarital genetic counseling and also premarital testing for thalassemia. And prenatal diagnosis was also introduced because of the thalassemia situation in the country. But it is very sad that still we cannot get it done in the country. We have to go abroad for any prenatal diagnosis. But we have now had affiliations with India, some of the hospitals in India, and we are able to send people just in time for them to do the test. And also, because of the thalassemia situation, the SHE program influenced establishment of many transfusion facilities and created high demand for thalassemia voluntary testing. The significant reproductive and psychological health challenges faced by carrier couples in the Maldives is known from this. And we have taken this screening program to the schools. We started screening children from schools of the age group above 12 years, and we have received some very interesting feedbacks from the screening programs. Some of the children at the age of 14, 15, they are in relationships. And since they don't know their carrier status, it is very, they were very shocked that they can be carrying the gene and without knowing they have taken a boyfriend or a girlfriend. And if they are at risk of getting a transfusion dependent child. So this was a major concern raised by the population, the public, and this is the challenge that we have been facing, and this is one issue we had to address. So the nationwide screening program has made a lot of changes in the policies, like mandatory testing for thalassemia before marriage, and also voluntary screening has become a necessary thing. And now we have a Thalassemia Act passed by the government, and it is mandatory for each parent to get their children tested before the marriageable age of 18. It is a very big challenge for screening to be conducted across the country, because we have isolated islands and each community is very, very closed. But it has been changing since people have started traveling to other islands for purposes of education or health or other needs. So now there are intermarriages between communities, but in the earlier days, it is a very, very condensed genetic pooling. That is one reason why we have pockets of different genetic variants of hemoglobins in different places. So we had to design our counseling package specific to the island need. We have certain islands with very high sickle cell carriers percentages. In some areas we find hemoglobin D, and in some areas we have hemoglobin E other than beta and alpha thalassemia. So we had to design our counseling packages according to the need of each island, and the risk of each island community is also being made aware for them when we give the counseling. Actually, the thalassemia challenges that were faced, the sexual and reproductive challenges that were faced by the thalassemia community made it mandatory to make the termination of pregnancy was legalized because of this situation. And it is very difficult to have a transfusion center in every island, but we find that each island has thalassemia carriers. There's no island which is not having any carriers when we did the screening. So it is a very difficult situation for the families to travel to another island to get a transfusion. But this has been improved by establishing about 108 transfusion centers across the country. But still, there are some children who needs to travel for a transfusion. So we have actually expanded, and also some of the choices that we give for couples who are carriers, some of them, they are in love and they cannot separate, so they decide to get married. But what are the options for these couples? The options that they can have is they can decide to not have children, or they can decide to have children and do a prenatal diagnosis and a termination of pregnancy in case of a thalassemia major. So we have long-term outcomes for couples, and we have to intervention strategies has to be implemented more. Development of island-specific counseling packages, consolidation of prenatal diagnosis services, development of simple monitoring and evaluation, infrastructure and capacity development, future application of genetic and genomic technology in the thalassemia and hemoglobinopathies. Actually, I would like to add that now these are my references. The thalassemic population is becoming adults. So they also fall in love and start families. But for them to have a child, they have to be thinking of their sexual and reproductive needs from the time of their puberty. Sometimes delayed puberty because of growth retardation in thalassemics when they're not properly treated. So all these has to be addressed. My topic is actually to help them have families, not contraceptives or other things, but to make them, their body ready for families to have children. And this is a very different topic from most of the topics that we discuss here. But we now face these challenges. I have listened to one of the thalassemia majors who is an adult, and now she has a beautiful baby, but she had a long journey to conceive a child. So these challenges is not in the country. They have to go abroad and have this baby because they had to do IVF and all that. Thank you very much for listening, and this is my story.